Good afternoon, my name is Greg. Today we'll be presenting the use case focusing on health and fitness. During the course of this demonstration, we're going to be walking through a workflow with our patient, Sophia Santana. She's 17 years old. She has a very busy lifestyle. She is both a full-time student and a part-time nursing aide. Now, we'll be walking through some clinical workflows and some population health workflows, and we'll be discussing how one's work and lifestyle can affect their health. And then we'll also be looking at how population health data can actually direct patient care. So at this point in our workflow, Sophia has already been checked in, and she's already met the nurse and had her vitals taken. So now she's meeting with the provider. Sophia has brought with her her yellow card, which is her immunization card, that contains a history of her known immunizations. Now, the provider notes that there are several immunizations on her immunization card that are currently not in the EHR. So one of the ways that he can obtain this data and get it directly into the chart is he can query the state immunization registry. So I'm going to hit this button, which is going to generate the HL7 V2 query message to the state registry. Now, the state registry is going to respond with the information that they have on the patient. That information is going to include the historical immunization data that the registry is aware of for the patient, and it can also include a forecast of immunizations that are due or due in the future. So in this return response, we see that one of the grouping of immunizations that we don't currently have documented in the chart is her HPV immunizations. So the provider is able to actually reconcile this data directly into the chart with just a handful of clicks. So this reconciliation screen, we can see the HPV, and for the sake of time, I'm just going to focus on this one. By clicking Add All, I can actually add these immunizations. Now, they are now part of her permanent medical record. Now, the provider also notices that there is a Hib vaccination that Sophia received when she was 2 years old. This information is not included in the registry's data, nor is it included on the patient's chart. So it's very likely that Sophia received this Hib vaccination when she lived out of state. So we're going to go ahead and document that Hib vaccination as a historical administration since we would like to have it as part of our system. Since this is a historical immunization, there's not a lot of data that we need to document, really just the immunization received and the date it was administered. Once I enter this data into her chart and click Accept, we're going to generate another HL7 V2 message to the state registry. So now the registry is aware of that historical immunization. Now, I mentioned earlier that Sophia is a nurse's aide, and as part of her job requirements, she must have the influenza vaccination. So as long as she's here for her office visit, we're going to administer that influenza vaccine. Now, since this is a new administration, there's some extra information that we need to include, including the lot number and the expiration date. So we're going to go ahead and document that now. We're also going to document her VFC eligibility. VFC stands for Vaccines for Children. We're going to document that she is not VFC eligible since this immunization is going to be paid for through her private insurance. Again, when I click this Accept button, we're going to generate another HL7 V2 message to the state registry so that it now has a complete picture of the patient's immunization coverage. I'm going to pass the microphone off now to the American Immunization Registry Association, who's going to discuss the value and the use cases for this information.
Hi there. So from behind the scenes, from the registry's perspective, what's happened is we've received over a SOAP connection, an HL7 QBP or a query search for patient. We've searched through however many millions of patients happen to be in that registry and returned the match to the EHR with what we have known to be their complete historical record of all vaccinations that they've seen up to the point. This gives whatever EHR or clinic the patient happens to be visiting the chance to have a complete record for any values that might be missing in there so that we can do a more accurate forecast. Based off of those results, we did see from the EHR's perspective that there was a missing single Hib historical vaccine which was sent over as a 25 VXU message. We responded in kind that we have added that to the patient's record. And finally, behind the scenes, we received an administered VXU message for the latest influenza, and again, we responded in kind. And as far as why we're trying to consolidate these records is, one is we're given the chance for any HR or any clinic to be able to have access to the complete patient's record, for all their immunizations, whether it's a different clinic or if it's come from outside of that jurisdiction. And this allows us to do things like coverage assessments, where in a case like this, you can see how well we're doing by an age demographic or by geographical locations and counties within the state as far as who's getting what vaccinations. We can also do things like being able to see how a certain clinic is performing. And from the actual IAS perspective, when someone is actually within the registry, here we can see a screen before we've received those vaccinations, and you can see that when they were in for this visit that there was an influenza vaccine due, and currently in their record we do not have reference to the Hib or influenza. If we refresh after we've received those latest vaccines, you notice that there is no longer an influenza vaccine recommended to be received, as they've already shown it in the system and it's been loaded through those messages.
All right, thank you. At this point, we're going to jump back into the clinical visit, back with the provider and Sophia in the office. So I mentioned earlier that when Sophia arrived, the nurse collected her vitals. Two of those vitals that were collected were her height and weight, and from that information, we can calculate the patient's BMI. BMI stands for body mass index. The provider notices that Sophia's BMI puts her in the 95th percentile for her age and gender. And for this reason, after discussing with the patient, they agreed that she would be a good candidate to be enrolled in a clinical research study related to obesity in adolescents. So one of the neat things that can be done directly from within the EHR is we can actually enroll Sophia directly into that research study without having to leave the chart. By kicking off this interaction, we are enrolling her in the study, and we're also kicking off an RFD exchange. RFD stands for Retrieve Form for Data Capture. This RFD exchange is occurring with the system NextTrials, who are conducting and running the research study. Now, once she's enrolled, NextTrials is going to need the clinical information that was collected during the course of this visit. We can actually, once we receive the form from NextTrials, this form can actually be auto-populated with the vitals we've already collected during the course of the visit without having to re-enter the data, nor having to log into an external system. So by clicking Submit, we're actually sending these vitals that we've already collected to the NextTrials system. Now, the benefits of this for NextTrials is that typically the workflow to collect the data for a patient enrolled in one of their trials is a manual process, meaning there's the opportunity for nurses or clinicians to enter incorrect data or fat finger data. The other benefit for NextTrials is that this data will be considered auto-validated as part of their trial and will not require a second step of sending a person to go validate that data on site, which can be very costly for the clinical trial. Now we're going to return back to the clinical visit with Sophia. After we've enrolled her in that clinical study, Sophia expresses that she would like to change her lifestyle, start eating healthy, and lose some weight. So for this reason, the provider is going to order a referral to a nutritionist so that Sophia can get a healthy work plan devised by the nutritionist. Now, once that referral is placed, the nutritionist will need to gather the data from Epic so that they can have it within their system at the time of their visit. Our nutritionist today is going to be represented by Qvera. Now, when Qvera kicks off the visit for that patient, they need to collect that data through a CCDA document, which is going to be routed through a system called Optum. Optum serves as both a routing system for this data as well as a repository for all of the patients that they collect over time. So I'm now going to pass the microphone off to Optum, and they're going to talk about the integrations that occur during this exchange.
Thank you. So my name is Xianhua from Optum. So today I'll try to describe how the interoperation can happen through the support from Optum infrastructure system. So in these use cases, after Qvera gets the referral, they will send us the initiating gateway request, and then we route that request to Epic system to get information from about the patient and return back to the Qvera nutritionist. After nutritionists update the care plan, they can update the data back to our system, as CCD, to our repository. After that, the document will be available for anybody who have access to our system to do further studies, like for University of Washington researchers to do the populational health research. From here, I pass to Covera.
Hello, I'm Terry from Cuvera. And when the patient arrives with the nutritionist, we're going to use a form that will allow us to gather her information. It'll pull the information from Epic, and then we will use it to create a care plan for the patient so that she can meet her healthy weight goals. As soon as I open this form, it initiates the XCA transaction to Optum to get the data from Epic so that this form can be pre-populated. So it has all of her demographic information already in here. Now, we gather information about her, we enter information about her occupation because that can also affect her healthy weight and allow us to make some plans based on that. Her behaviors that we're going to look at are we're going to look at sleep, we're going to look at frequency and amount and time, duration of her exercise. We're going to look at her vegetable and fruit intake and the amount of water that she drinks every day. This will allow us to come up with a care plan so that when she leaves here, she has ideas of what she can do to help herself meet her goals. So as soon as I click Update Patient Chart, this is going to initiate a transaction to Optum that will create a healthy weight CCDA document, adding my care plan and the information that we've added in here to Optum to put it into the repository so that anybody who has authorization can access that data and use it how they need to use it. For instance, with Community Health, which is the state of Washington, and we're going to pass it off to them now.
Thank you. So, I'm from the University of Washington, but in this role, in this scenario, I'm playing the role of Washington State Department of Health. And what we're going to demonstrate two aspects today. One is how public health can use this information they're receiving from healthy weight CCDAs to look at the health of the population and to target population level interventions. And the second thing we're going to demonstrate is how public health can then provide that population level information back to the provider using the Smart On Fire app. Okay. So first of all, here we have proof that we've received the Healthy Weight CCDA. So this is Sophia's Healthy Weight CCDA that we retrieved from the repository, and it has demographic information and healthy behavior information such as frequency of vegetable intake, sleep, and physical exercise. So what public health can then do with this data is we collect this data from the whole population of people with healthy weight CCDAs and aggregate it up to get a look at what's happening at the population level. So at the top level here, we're showing physical activity by age group and sex, and the bottom level, we're showing healthy eating habits by age group and sex. And in this case, the healthy eating habits are taken directly from fruit and vegetable consumption. So this is a dashboard that public health can use to get a quick overview of what's happening in our population with regard to healthy eating and physical activity. So one of the things they can see straight away in this particular population, males across age range are eating less healthy than females. So if we decide to do a intervention at the population level targeting healthy eating, that is something we really want to know, so we have to consider how do we tailor our messages for males in particular. Another part of a dashboard we can show is geographic distribution. Because we're getting a demographic information, we can look at this case, median BMI by zip code within Washington State. And as another example, if you were thinking about it at a local health jurisdiction, you could look at it for just a single county. So in this case, this enables us to see, are there any geographic patterns to BMI? Are there specific zip codes or counties that we should perhaps target for an intervention? Now, the third part of a dashboard we're going to show today, which we think is very exciting, is looking at the effect of occupation. So because we're collecting occupation as part of this Healthy Weight CCDA, we can put on our dashboard here, for example, how is BMI or healthy behaviors related to occupation? Now, we spend, working adults spend on average over half their waking hours at work. So it's inevitable that there is an interplay between where you work, what your occupation is, and your health. And so this is a way that public health can get information on that. And so, for example, down below we have slightly drilled down looking at percent obesity by occupation group and now breaking it down by gender. And we've highlighted food preparation and serving related occupations because although we saw over the whole population that females were eating more healthy than males and getting better exercise, in this particular occupation, in terms of obesity, the obesity rates are actually higher in females than males. So again, if you are looking at developing a targeted intervention at the population level, this is all very important information to have if you're thinking about how to do it by occupation. So what we've shown so far is really a demonstration of a population health level dashboard that public health can use to quickly get an idea of what's happening in my population and use that to inform targeted interventions at the population level. I'm now going to hand it over to my colleague Bill Lober, also from the University of Washington, to talk about how public health can provide that information back to the provider at the point of care.
Great, thank you. As Ian said, we wanted to talk about two things. The first of those is how public health uses these data on a population level to develop interventions and to aim those interventions at population groups where we can make a difference. So we talked about aiming for age, gender, we talked about aiming for geography, and we talked about aiming for occupation. I would like to go back to the clinic visit and show you a little bit more about that second idea that we wanted to show, which is how the data that public health gathers, how the knowledge that public health generates can be brought to bear in an individual clinical encounter to give the provider tools to directly help the patient. And so that, for a long time, has been a goal of public health, is to take the knowledge that we create and to bring it back to improve the health of individual patients. And so we will demonstrate an application that was developed using the Smart on Fire framework by public health and which runs inside the EMR, in this case, which runs inside Epic. That application does a couple of things. It uses the FHIR protocol to get clinical information from Epic, and it uses a similar protocol to get information from public health, and it brings those together to present tailored information that can be used to motivate behavior change. So as an example, the data that we get from Epic is weight and height, and we use that to compute body mass index. And I want to show you 3 examples of tailoring those data. The first example is that we take the individual patient's body mass index and display it on a graph with her age. And then we're also showing on that graph the median BMI for women who get different levels of exercise. The median BMI for women of different ages who get extensive exercise in green, who have adequate exercise levels in yellow, and who have insufficient exercises in red. So we, as a provider, I might use this information to talk a little bit to the patient about her level of exercise and what other women like her, what women at different ages are likely to expect. The second thing the second level of tailoring that I want to show you is how we can take information that was gathered by the nutrition consult outside of the electronic medical record and bring that information into the encounter. So we're looking at 4 types of information here. First of all, the nutritionist is able to do a more detailed occupational assessment, looking not only at what kind of work the patient does, but at the nature of that work, that it's rotating shift work, at the amount of work that the patient does, when the patient started working, etc. The second area are the second 3 areas that I want to talk about are 3 health habit areas: physical activity, nutrition, and sleep. And in each of those, the nutritionist was able to assess both the patient's current health habits, how often she gets physical activity, what kinds of things she eats, how well she sleeps, as well as assessing a readiness to change. And we present that in a simplified format here, but it helps the provider understand, given the limited amount of time available, where can that provider make a suggestion that will have the greatest impact and that the patient is most ready to receive. So physical activity, in the case of nutrition, we've organized both the habits that we think are the habits that are healthy that patient follows, as well as separating out the less healthy habits, the opportunities for improvement. And then finally, the third level of tailoring is that we can, knowing the patient's occupation, we can provide job-specific health tips for the patient. And in this case, what we've done is to, in this case, because the application knows that the patient is a healthcare worker doing shift work, we can bring up an American Nursing Association one-page handout that talks specifically about how to do rotating shift work and maintain healthy habits in the healthcare field. And if any of you are in the healthcare field, we have copies of that handout up here today. So to step back a little bit from this individual demo, I want to recap what we've shown in this in the scenario here. And really what we've tried to do is demonstrate 3 different ways in which population health data and the interplay of that data with the EMR supports population health and public health. One of those was through the use of standardized immunization registry messages exchanged with the immunization registry through web services. The second is with use of the standard IHE retrieve form for data capture profile and the use of that profile to support clinical trials enrollment and capture of information about a patient in a clinical trial. And the third of those is this idea of using the CDA, using a standardized way of expressing clinical visit summary data, of sending that CDA from the EMR to a consult service, who then adds information to that summary. And then public health is able to look across many of those summaries, build knowledge about that aspect of health in the population, and using Smart on Fire to bring that knowledge back to the provider at the time that the provider can successfully intervene in the middle of a patient encounter and suggest to the patient ways to improve their habits.